Good evening. Thank you all for joining us this evening. I'm Claire Saxton. I'm Vice President of Education and Outreach at the Cancer Support Community. Welcome to our webinar, Frankly Speaking About Cancer, Multiple Myeloma. If you need technical assistance and you're here live, you can email outreach@cancersupportcommunity.org, or you can use the chat button either at the bottom or top of your screen to get technical assistance. Before we start, I'll go over some reminders and housekeeping items. If you're joining us live and would like to listen using your telephone, please dial in using the numbers you see under the audio settings and join by phone call. Otherwise, you can listen to the webinar using the speakers on your computer, tablet, or smartphone internet connection by clicking Join with Computer Audio. Today's call is being recorded and will be available on our website at www.cancersupportcommunity.org/multiple-myeloma and on Facebook, on Cancer Support Community's Facebook page on Tuesday, August 18th. For today's webinar, we will first have Dr. Craig Cole, a multiple myeloma expert, give his presentation. Then we'll open the discussion up to the audience during the question and answer session. If you are listening to us live and you'd like to ask a question that will be answered by Dr. Cole, please use the Q&A button either at the bottom or top of your screen. You can submit a question at any time during the live event, but we're going to hold the questions until the end to answer them. And then at the end of this webinar, we'll have an evaluation survey that only takes a few minutes, but gives us valuable input to improve future webinars. We hope that you will take that survey at the end of our program. I'd like to now introduce the Cancer Support Community and just quickly talk to you about the services that we offer to cancer patients and their loved ones. Cancer Support Community is the largest professionally led nonprofit network of cancer support worldwide. Cancer Support Community is dedicated to ensuring that all people impacted by cancer are empowered by knowledge, strengthened by action, and sustained by community. We offer the highest quality social and emotional support online, over the phone, and through our local cancer support communities and Gildas clubs across the US and in 3 additional countries. On this next screen, you'll see some of the resources we provide at the Cancer Support Community. The first one there is the Cancer Support Helpline, which is staffed by licensed professional counselors and trained advocates who are available to assist you Monday through Friday, 9 a.m. to 9 p.m. Eastern Time. Translation is available in 200 languages. Through the helpline, you can ask to participate in our Open to Options program, which is a research-proven program that can help you prepare a list of questions to share with your doctor. We also have our Frankly Speaking About Cancer program, which this webinar is a part of. Frankly Speaking provides trusted information on a variety of topics important to people affected by cancer. Information is available through print and digital publications, online, and in-person programs. For the complete list of publications, please visit orders.cancersupportcommunity.org. I would also like to introduce our Cancer Experience Registry. Through the registry, you can help others by sharing your cancer patient or cancer caregiver experience. You begin by answering survey questions. Those answers and the answers of others are used to develop education and support resources that speak to patients, caregivers, and their needs. For more information or to join the registry, visit cancerexperienceregistry.org. My Lifeline is the Cancer Support Community's online platform that helps connect cancer patients and caregivers with friends and family in order to reduce stress, anxiety, and isolation. On My Lifeline, you can create your own private website that friends can come to see how you are doing and any help you might need right now. You can also use My Lifeline to connect with others like you on our discussion boards. Sign up at www.mylifeline.org. And finally, we'd like to invite you to join our grassroots network. that will send you emails updating you on policy issues to help ensure that people touched by cancer have access to quality, comprehensive cancer care that includes social and emotional support. We will also let you know about opportunities for you to make your voice heard with federal and state policymakers if you sign up at cancersupportcommunity.org/join-our-movement. Now it is my great pleasure to introduce our speaker, Dr. Craig Cole. Dr. Cole is a board-certified hematologist who received his Bachelor of Science degree in physiology at Michigan State University and the School of Lyman-Briggs. Dr. Cole went on to receive his doctoral degree at the Ohio State University College of Medicine and completed his internal medicine residency and hematology fellowship at the University of Michigan. He did post-fellowship laboratory research at the Jerome Lipper Multiple Myeloma Center of Medicine at the Dana-Farber Cancer Institute. After that, he became an attending hematologist at Gunderson Health System in La Crosse, Wisconsin, which is the western campus of the University of Wisconsin School of Medicine and Public Health. Dr. Cole then returned as a clinical assistant professor at the University of Michigan in the Division of Hematology Oncology, where he continued to focus on clinical research in multiple myeloma. In May of 2019, he returned to Michigan State University College of Human Medicine at Breslin Cancer Center as the Director of Clinical Research in Hematology and Multiple Myeloma. Dr. Cole has participated in over 50 clinical trials in multiple myeloma and malignant hematology. Today's interview with Dr. Cole will give an overview on the basics of multiple myeloma treatment and also advances in treatment. So I will now ask Dr. Cole to start us off by explaining what is multiple myeloma.
Well, thanks, Claire, and thanks everyone for coming in this evening. And your time spent with this is incredibly valuable, and I'm honored and very happy to discuss definitely a passion of mine. So myeloma is a cancer of the plasma cells, and what does that mean? Well, the plasma cells are part of the immune system, cells of the immune system that live inside the bone marrow. And normally those cells produce antibodies to help fight infection. And just like any other cell inside the body, if the plasma cells become cancerous, then they will produce lots of that antibody or protein. And actually those antibodies produced by the cancerous plasma cells or the myeloma cells don't help the immune system. They actually can hurt the immune system. And so, and that's how we keep track, diagnose all of the plasma cell disorders, including multiple myeloma. So myeloma is a cancer of the plasma cells that live inside the bone marrow. It's detected initially by looking at the protein produced by those plasma cells. And one unique thing about myeloma is that, unlike a lot of other cancers, the myeloma cells are very dependent upon the bone marrow stromal cells, or the cells inside the stroma or the makeup cells that are inside the bone. And so myeloma, unlike other cancers, really is dependent on going to other areas that have bone marrow stromal cells. So when you see someone that has a myeloma, they can have lytic lesions or bone lesions because the plasma cells will go to the bone, which also contains bone marrow stromal cells that the plasma cells are dependent upon. And so that's kind of a brief overview of myeloma. Myeloma is the second most common type of blood cancer. It is second to lymphoma. And there were, I believe in 2020, there are going to be 131,000 people living with myeloma in the United States, which is dramatically increased from 15 and 20 years ago. It is, and we'll talk about it in a bit, but it's usually a cancer of older individuals. As I get older, that's not so old, but around over 60 and 70 years of age. Yeah, so that's myeloma in a briefest.
Thank you. And who is at risk for multiple myeloma?
Yeah, and that's a really good question. We know some things about a myeloma. Again, that it is that people that are older than age 60 are more likely to get myeloma. Men, the incidence is higher in men than in women. And one important point is that and can you see my slide? Perfect. So one thing that we know about myeloma is that it does have an ethnic prevalence, and specifically that people of African descent have twice the incidence of myeloma than Caucasians. And this increase in incidence actually runs through the entire continuum of the disease. So the precursor disease to myeloma, we'll talk about in a bit, is the monoclonal gammopathy of uncertain significance, where there are only a few plasma cells in the bone marrow and a very low amount of protein. And MGUS is very common, but that's increased in people of African descent. It is higher, and which leads to it being a higher incidence of smoldering myeloma and ultimately multiple myeloma. So here is some of the SEER registry data, which is the census of myeloma patients in the United States. And Africans and people of African descent and African Americans, the incidence is about almost 12 per 100,000. As compared to all races where it's 5.8 per 100,000. And Hispanics, 5.2, Caucasians, 5.26, and Native Americans and people of Asian descent actually have a very low incidence of myeloma. And so, one of the, not necessarily risk factor, but the prevalence of myeloma is higher in people of African descent, which is why when you look at all comers for myeloma in the United States, that the incidence in per population is 19% of myeloma patients are African descent, which is higher than the national average of African Americans, of African Americans in the United States. Blacks and African Americans have the highest incidence of myeloma of any ethnic group in the world. And that covers people in Africa and again, of African descent across the world, that we have the highest incidence of this disease.
Do we know why?
We don't know why. In fact, there's one other slide I want to show you, is that this is age as the incidence, how it increases with age, and if you look, that actually African Americans begin to have a myeloma at a younger age than Caucasians, and as we get older, the incidence of African Americans rises, and actually it's very high in our oldest group, in the 80-year-olds, as compared to all other races. But we don't know why the incidence is higher in African Americans versus other groups. We know that the incidence for men and women are climbing for both Africans and Caucasians. For both men and women, the incidence has been climbing. The good news is that the mortality associated with myeloma, with all of the new therapies, the clinical trials that have been going on, have been decreasing for both Caucasians and people of African descent. But why do African Americans have a higher incidence of people of African descent is a very hot area of research, and so far we haven't found the answer yet. And it's because we need to do large studies of lots of people of African descent not only that have myeloma, but have family members that have myeloma. We've looked over the decades, and the racial incidence can't be explained by tobacco or alcohol or socioeconomic status. It's likely something that is genetic. We just haven't found, that the genes or the set of genes that are related. We do know that obesity increases the risk, and exposure to ionizing radiation may have an increased risk for the disease. Chemical exposures, diesel exhaust, pesticides, metal exposure, particulate exposure, we know that are related. But why is it African Americans? That is really the question that a lot of research is directed towards.
Well, thanks for giving us that background on who is at risk, even if we're not quite sure why. So I'm going to move into asking about, I've heard a lot about CRAB symptoms, and ask you what is a CRAB symptom and why are they important in multiple myeloma?
Yeah, so CRAB is an acronym for the C stands for calcium or high calcium levels. And that's a sign and symptom of myeloma, because myeloma has a tendency to go to the bone. It causes the bones to be weakened and destroyed, which releases calcium in the blood, which can cause people to be confused and very fatigued. The R stands for renal, or kidney, and patients with myeloma can sustain kidney damage because that protein being produced by the myeloma cells can get stuck in the kidney, because the kidney filters the blood and removes the poisons in the way of urine. But that protein produced by the myeloma cells can actually get stuck in the kidney and cause kidney damage. And that's the R for renal insufficiency or kidney problems, which are usually detectable on lab tests. The A stands for anemia, which is low red blood counts. And because those myeloma cells live inside the bone marrow, because they can start to take over and push the normal cells out, red blood cells are made inside the bone marrow also. And the myeloma cells will push the red cells out of the way. Actually, will start to destroy some of the red cells in order to get more access to those bone marrow stromal cells that we have mentioned. So anemia with a hemoglobin less than 10 is another sign of symptomatic myeloma. And then finally, the B stands for bone disease or lytic lesions inside the bone, where the myeloma cells will work inside the bone marrow biopsy, start to push other cells out, and then they will move to other bones to find those bone marrow stromal cells to get nutrients and cytokines to grow. And when it goes to those other bones in the body, it actually will start weakening the bones and start to cause holes in the bones or lytic lesions that are detectable by x-rays. The reason that it's important is that we put that in the context in diagnosing a patient with myeloma. When we see that high protein level made by those plasma cells, we then look to see, is it causing any tissue damage? Is it causing damage to the bones or to the kidneys or to the bone marrow, causing anemia? The other thing that CRAB symptoms and acronym helps us with is that in smoldering patients, when we're watching their smoldering patients, we'll talk about in a bit, we look to see if they develop CRAB, because we want to avoid those symptoms from getting worse if they occur. And also when patients have received therapy and they're in a remission, that if their disease comes back, we know watch for those CRAB symptoms or signs coming back. So we watch the calcium and we watch for anemia, and we sometimes look for bone lesions if we think the myeloma is recurring. So CRAB is really something good to know, not only at the time of diagnosis, not only in observation with smoldering patients, but also through the entire course of the disease.
So you've talked about MGUS and smoldering and active multiple myeloma. Can you explain the differences between those?
Yeah. So let me show you. And and can you see that? Is that perfect? So MGUS, or the monoclonal gammopathy of uncertain significance, got a long name for basically there being some mutated plasma cells in their marrow, but not very many. And so patients that have, and MGUS is very common. In people of African descent, we think that MGUS can be about 5 to 6% of the population. Most people don't know they know it because you need to do blood tests in order to find it. But MGUS is patients have very small number of plasma cells. They have very small amount of the protein made by the plasma cells, and that there are no symptoms. There are no of those CRAB criteria that are CRAB symptoms that are occurring. And that has a very low risk of turning into myeloma, about 1% per year. So it kind of moves along very slowly. Smoldering myeloma is the next step up. So that's when there are more plasma cells in the bone marrow. So the normal amount of plasma cells in the bone marrow is 1%. If you have more than 10%, then that means that there are more plasma cells, which is more akin to smoldering myeloma. And because there are more plasma cells in the marrow, there's more protein being made. So the M protein, or the myeloma protein that we measure from those plasma cells, are higher. But again, with smoldering myeloma, there are no symptoms. So there's none of those CRAB criteria. The calcium and the kidney function's normal. There are no bone lesions. And the risk of turning into symptomatic myeloma is higher because there are more plasma cells. So it's more like 10% per year to develop active myeloma. And then finally, there is multiple myeloma, when there's a high protein akin to that of smoldering myeloma. There's more than 10% plasma cells in the bone marrow, like smoldering myeloma. But unlike smoldering myeloma, there's symptoms associated with it. And again, it's those CRAB symptoms of high calcium, renal insufficiency, anemia, and bone lesions. Recently, or I should say about 5 years ago, we actually came up with, and we, the myeloma community, did research and found that there are symptoms, there are signs which show that there is imminent cause of someone developing those CRAB symptoms. That if a myeloma patient has greater than 60% plasma cells in their marrow, which is a lot of plasma cells, or if they're free light chain, the fragments of protein made by those plasma cells, if they have a high free light chain, or if on an MRI they have more than one lytic bone lesion, those patients have a 90% chance of developing those CRAB symptoms within a year. And so in the past few years, we've actually been treating those patients, watching them very closely and treating those patients because we want to avoid them having those CRAB symptoms. And so the new high-risk features, or sometimes it's called slim CRAB, is when patients are asymptomatic, but they have those features, the high bone marrow, the free light chain, or the more than one lytic bone lesion. And so that's the scope of plasma cell disorders.
Great, thank you. And so what kind of treatment would you expect for MGUS or smoldering myeloma?
So that's a really good question. And they're all good questions. But that's a really good question. So my answer would be clinical trials. So for MGUS, because the risk of having symptomatic myeloma is so low, that we usually observe MGUS. And so we do blood tests to see if the protein is changing at all, sometimes every 6 months to yearly. And we educate the patients in knowing what to look out for, that if they have pain or if they have fatigue, to let us know. So for smoldering for MGUS is observation. For smoldering myeloma, that's right now the standard of care is observation. However, there have been some clinical trials that have resulted just in the past year that have suggested that the highest risk smoldering patients, the ones that are very close to developing symptomatic myeloma or beginning to have those high risk features, the patients who have smoldering myeloma that instead of their protein being stable over the course of years, it's beginning to increase about 10 to 20% every 6 months. Those are the patients that we really think about treating them with low dose therapy. And that is fairly controversial. And so it's a very good discussion to have with your doctor if you have smoldering myeloma and it seems to be evolving, to discuss, would I be a candidate for a suppressive therapy? But that, again, is controversial because that data just become available. And so the myeloma community is still working out of how to sort of put that in the context. But, if someone has smoldering myeloma, my first recommendation would be clinical trial. And again, usually for most patients, we do observation.
Okay, so could you talk a little bit about the kinds of treatment available for active multiple myeloma?
Yes. And so when you talk about treating active myeloma, the first thing that I discuss with my patients is myeloma stage, because stage does count, and I'll show you in a bit. But there are the new staging criteria that we have is stage 1, 2, and 3. And stage 1 means that there are not a lot of plasma cells by a test that we use called the beta-2 microglobulin. And LDH is a blood test that helps us tell how many plasma cells are actively dividing. And so the lower the LDH, the less the plasma cells are actively dividing. But probably the most important part about stage 1 and stage 3 are the cytogenetics. That when you crack open those plasma cells, you look to see what mutations occurred that may have played a role in causing the disease. And there are certain mutations that are discovered on the bone marrow by doing FISH, or fluorescent in situ hybridization cytogenetic studies, that look for specific mutations that occur that make the myeloma more difficult to treat. More difficult to get the protein down, more difficult to keep it down after therapy. And so especially with patients that have stage 3, and in particular, patients that have high-risk cytogenetics, we then look at the breadth of therapy that we have. And basically for newly diagnosed myeloma patients, we start with a frontline induction regimen. And I listed a lot of the induction regimens here with Velcade, Revlimid, and dexamethasone, or VRD, or RVD.
So we don't see a slide if you were referencing a slide.
Oh, I'm sorry.
That's okay.
Oh, there it is. I'm sorry. Do you see it now? Okay, perfect. And I'm sorry, and this is the stage. And I would have your eye lean to the high-risk cytogenetics, and those are the chromosome abnormalities that are associated with myeloma that can be more difficult to treat, where we may decide on using a different type of therapy than the standard RVD or VRD. So VRD is kind of the standard therapy that we use to treat myeloma, standard risk or stage 1 or stage 2 myeloma. But there are a lot of other therapies to pick from, and these are all evidence-based. And the good news is that when you discuss with your doctor about the different therapies, is to have a discussion about which therapy works best for me. Because some patients don't want to come in for IV therapies, especially during COVID, and then Enlara, Revlimid, Dex is a good option there. Or they want to use some of the newer therapies like the antibody therapies. One thing that's on the induction therapy is that Kyprolis, Revlimid, Dex, And there have been recent studies to show that standard risk patients don't benefit from that therapy so much, and is better served with the RVD or the VRD. But the high risk patients is where we use clinical trials, and KRD becomes very handy. After induction therapy, patients go through consolidation, and we usually do stress a stem cell transplant as consolidation therapy after we get the disease under control. And then we follow that up with maintenance therapy to keep that, once you got the myeloma down, once you've punched the disease down, to keep it down there. And so when you look at, the goals of therapy, when patients start out with myeloma, symptomatic myeloma, it's obvious. So the Iceberg model is what we use to discuss myeloma, what I talk to my patients about. When they come in, they have more than 1 trillion plasma cells. They have lots of protein, and it's obvious they have myeloma. But as we go through treatment, they go through, the number of plasma cells become less and less, and it's not so obvious that they have myeloma. And so at diagnosis, they start with a lot of plasma cells. With continued therapy, they'll have a 50% reduction in their protein, because remember, the more plasma cells you have, the higher the protein. The lower plasma cells you have, the lower the protein. And so if you have 50% reduction, then that's a partial response. If you have 90% from the time you're diagnosed, then that's a very good partial response. That's when we usually recommend patients undergo a stem cell transplant. And if there's no protein present, then they're a complete remission. Having a complete remission doesn't mean that the myeloma is gone. There could still be some plasma cells there. And so there are new technologies, including minimal residual disease testing, trying to improve upon the protein testing to see if there are any plasma cells left. And so again, the treatment is there to push the disease down as low as it can be. And then the consolidation pushes that even further, and maintenance keeps it down there.
So that's a great visual to see what the therapy is trying to do. Can you talk a bit about relapse and how treatment is different when relapse occurs?
Yes. So with relapse myeloma, so one thing that we haven't done yet is we haven't found a cure for myeloma. And so patients with myeloma, eventually, after they have induction therapy and have their response, will at some point have the disease come back. And how do we know when the disease comes back? Well, we had mentioned that the protein will go up. The more plasma cells there are, the higher the protein. So when the myeloma relapses, the protein will go up. And if it goes up more than 25%, then its lowest value, or patients begin to have symptoms. So if before they didn't have anemia, then they started to have anemia or having kidney problems, then we call that progressive disease or relapse disease. And then the goal of therapy is to discuss with the patient a second line of treatment to again push the disease back down. If we've knocked the other, I don't know anything about boxing, to be honest with you, but if you're boxing, you knock the guy out with your 1-2 punch, the induction therapy plus a transplant, that if he starts to get up again, the protein starts to go up. You don't wait until the bad symptoms happen. You don't want him to get back on his feet. When he starts to get up, then you hit him again and push him down again. That sounds kind of violent. And what we can do, there it is when patients have relapse disease, that there is an entire menu of different therapies. Usually what we recommend is that the selection of therapy should be 3 drugs. People are very different. Their relapses are very different. And so it can be very different from person to person. But usually a 3-drug therapy for relapse, usually, and we do usually reach for that antibody. The antibody therapies, which we can discuss later on, are really the mainstay of relapse therapy, and we're moving into newly diagnosed therapy. And on the slide, the therapies that are in bold are the ones that are approved by the FDA. And so we discuss with the patient, talk about what their goals of care are, what fits into their lifestyle, and then work at finding the next therapy. And one thing that I would mention is that 4 drug therapies for relapsed myeloma are on the horizon and in clinical trials. And there have been all the drugs that are that I have in bold at the bottom of this slide, all the things that have been approved. Gosh, that's been in the past year. Selinexor, isatuximab, Pomalyst, Dex in combination with any of the other therapies. Dara under the skin, so there's a sub-Q formulation of the antibody therapy, daratumumab, and blintanumab was just approved, a week ago for relapsed myeloma. But all these therapies wouldn't be here if it weren't for patients involved in clinical trials. And so when I have a patient that has relapsed myeloma, my first discussion that I have is standard of care in clinical trials.
So there clearly is a lot new happening with multiple myeloma research and treatment. Can you tell us a little bit more about what's on the horizon?
Oh boy. I can absolutely, the reason, I've had a passion for this, for multiple myeloma for, I guess now 15, 20 years. And part of that passion comes from that new things are constantly coming out. The research is absolutely infectious and incredibly exciting. And literally every day I wake up and I'm just excited about the next thing that's happening. And in this slide, so, asking that, I could go on for a month talking about new therapies and the things that have me excited about myeloma. But, for newly diagnosed myeloma, when there wasn't a lot of research going on with smoldering myeloma, or with newly diagnosed myeloma, there's been some really landmark trials that are really changing the game with newly diagnosed. I mentioned earlier that we have some recent data where they compared Kyprolis, which is a second-generation proteasome inhibitor, or a second-generation Velcade, Kyprolis Revdex against the standard RVD, and for standard risk patients with myeloma. And that study was really important because it told us that there really wasn't a lot of difference in outcomes between using KRD and RVD for standard risk patients, which was really critical to know, especially in clinical trials moving forward. For high-risk patients, we still need some more data about for standard risk. That helped a lot. There are also lots of new studies and publications that are using 4-drug therapy, that are using the new antibody therapies combined with standard therapies, combined with the backbone of our previous therapies for both high-risk myeloma and with standard risk myeloma that have really shown incredible results. 100% response rates, 80% of patients going into complete remissions. I mean, it's remarkable. For maintenance therapy, there are also some really exciting results. And one, I think, really important study about maintenance therapy was a stamina trial, which in part of the stamina trial, they looked at patients that had myeloma with standard induction therapy that then went to transplant. And then after transplant, we're on maintenance therapy. And the interesting thing about the stamina trial is that patients were able to elect to either stop their maintenance therapy at 36 months or continue. And interesting enough, about half the patients decided to stay on, half the patients decided to stop. And the interesting thing about the stamina trial and the patients that went off is that their myeloma recurred sooner than the patients who stayed on, which is telling us again that the longer we use maintenance therapy, the longer we can keep people in those responses. Now, the longer we stand on the boxer after we knock him out, the longer he's going to stay down there. And so that was very helpful. And we're getting more information on Ninlaro, or the oral version of Velcade, as maintenance therapy. What has been incredibly exciting and a very, again, active area of research has been the immune therapies, using the antibody therapies, but also using CAR T cells and bispecific antibodies. And those two therapies are where we get the T cells. So the T cells usually patrol for cancer. And so what keeps us from getting cancer through our lives is that these T cells discover mutated cells and destroy them. When patients have cancer, it's because the cancer cells have found a way to avoid those police cells or those quality control cells and grow. So CAR T treatments are when we reprogram your T cells to go hunt down myeloma cells. And for very, very relapsed patients who have seen 5 and more therapies for relapses, those results have been really a landmark and incredible. When we used to get 20% response rates in patients that have multiple relapse myeloma, they're now pushing 80, 90% response rates for CAR T cells. The bispecific antibodies actually do something very similar, but instead of re-engineering the patient's own T cells, the bispecific antibodies bind to the myeloma cell, they bind to the T cell, bring them together, and let them duke it out. So instead of reprogramming the cell, the bispecific antibodies bring the myeloma cell and the cancer-destroying T cell together, and the T cells destroy the myeloma cell. And then again, another very hot area of research are the second-generation antibodies, or the antibody-drug conjugates. So daratumumab and elotuzumab and isatuximab are all antibodies that stick to myeloma cells. The new antibodies, and actually the main antibody in the DREAM-6 study is blintanumab, that was recently approved a week ago. And that drug not only attaches the myeloma cell, the antibody not only attaches the myeloma cell to destroy it, but it actually gives a Trojan horse of a chemotoxin inside the myeloma cell that goes nowhere else in your body except for the myeloma cell and destroys the myeloma cell from within. And then there are lots of new drugs that are in development, but the two that I'm really excited about are the new Cleomode, which is the second, or I guess third generation Revlimid. Incredible drug, incredible new drug for that is in the same family as Revlimid. And the Bellini trial, which we can talk about in a bit, but the Bellini trial uses a drug called venetoclax, which the myeloma cells, the way they stay alive is that they don't know how to die. The myeloma cells use a protein called BCL2 to stay alive. And venetoclax inhibits BCL2, so all of a sudden, those myeloma cells are kept alive by this protein BCL2, no longer can stay alive, and they actually die, especially when exposed to bortezomib. And then there's specific types of myeloma patients that have specific cytogenetic abnormalities, and in particular the 1114 translocation, that are especially sensitive to venetoclax. And so that is just a smattering of what I could talk all night about that, to be honest.
Well, and it really is kind of amazing to hear you talk about it, because re-engineering your own immune cells to fight the myeloma, and bringing your fighter cell to the myeloma and sticking them together, and being able to deliver one molecule of chemo to the one cell of myeloma just sounds like science fiction. Um,
If you were to if you were to go back to when I first started this, my goodness, when Revlimid and Velcade were all brand new drugs, and if you told me about CAR T or just antibodies, we never thought antibodies would ever work for myeloma, because we said, gosh, the immune system doesn't work very well, and et cetera, et cetera. And that has been a home run. And so and the home runs just keep coming over and over and over. And so it's incredible.
So I'm going to switch gears for a minute before we go to questions from our audience and ask, what changes are you seeing now in treatment as a result of COVID-19? Because I know that it's a big concern of everybody out there.
Yeah, and what the first thing that I tell my patients, and I tell everyone I saw today, all the myeloma patients I saw today, I kind of tell them the same thing, that this too shall pass. And so the changes that I see and the changes in my practice is that is to to tell patients that this is something transient, and that we'll get through this, and that we will know more about the immune system, about viruses, and we're learning a lot about myeloma during the COVID pandemic. The one thing that, or the several things that we talk about, and I talk about with my patients during the pandemic, is to make sure that my patients are aware that of their vulnerability to COVID infection, and in particular the bad reaction, or the cytokine release, or the lung issues that are associated with severe COVID infection. That the patients with myeloma, because it's a cancer of the immune system, have a weakened immune system, and sometimes their therapies can weaken their immune system in addition to that. And so they need to be aware that, with the recommendations from the CDC, that they really do need to be very aware of that, and also to make their families aware to adhere to those recommendations of social distancing and cleaning surfaces and washing your hands frequently. And we've talked, and we do try to avoid travel as best possible. So I'm doing a lot more telehealth. So, especially my smoldering patients and and patients with MGUS, we've been doing telehealth appointments, and some of the second opinions that I see, I do telehealth, so they don't have to travel to see me, and we try to, where appropriate, we try to use oral therapies versus IV therapy, so patients can take their myeloma therapy at home and not have to come back and forth to the clinic and driving. And all that, is to limit contacts, to again try and reduce the risk of exposure to COVID. And so we hope to get more information about myeloma patients specifically and COVID over the next several months, as we begin to collate more data on the myeloma patient experience.
Thank you. So we really appreciate you talking with us about this, Dr. Cole. If folks want some more basic information regarding multiple myeloma, you're always welcome to visit cancersupportcommunity.org/multiple-myeloma. We have excellent resources for multiple myeloma patients and caregivers, including information about treatments, videos from patients and caregivers talking about how they cope, videos from healthcare providers like Dr. Cole explaining some of the technical issues, and then we also have a multiple myeloma patient guide. But at this point, we would like to open the discussion up to our live audience. We may have answered some of your questions during the presentation. However, if you have any additional questions, please feel free to click. There's a Q&A box at the button where you can type in your question. If you're on a computer, you can find the Q&A button at the bottom of your screen. If you're on a phone or a tablet, you can find the Q&A button at the top of your screen. And one of our first questions is, do any alternative approaches help when used at the same time as RVD treatments or other standard therapies? So some things that the questioner asks about are things like hyperbaric oxygen, acupuncture, cannabis, homeopathy.
So that's a really good question, and as with a lot of the complementary therapies, there hasn't been a lot of study that with myeloma patients. One thing that we do know, and that there have been at least laboratory tests done, is that green leafy vegetables and things that are green actually contain a chemical that in the laboratory inhibit the bortezomib. We don't know if it has any clinical relevance at all. What I tell my patients is that on the day that they get their Velcade therapy or they take their Ninlaro, to not eat green leafy vegetables on that day. That I tell them to eat green leafy vegetables all other days, because that's very good for you. But that one day, and I would say that because we don't know about a lot of the supplements, and because Velcade or bortezomib has that sensitivity, that would be one day where I wouldn't recommend taking a lot of complementary medicines. Over the years, what we found is that one very powerful agent that can help with myeloma therapy is a well-balanced diet, which isn't and limiting processed foods, which doesn't, there aren't going to be studies and a lot of literature saying, eat a well-balanced diet because no one's going to pay for that. But really, when you look at patients who do well, exercise, staying active, drinking lots of water, and a well-balanced diet with limited processed foods definitely helps more than hurts. And has many more benefits. Those macronutrients in those foods really help. Also, is more and more evidence that acupuncture does help with pain and neuropathy, and so that's a very good point. But for a lot of things, a lot of specific agents, there haven't been a lot of studies really to prove or disprove them.
So Larry is asking, and especially with the new therapies that you're talking about, is there an updated life expectancy of someone with multiple myeloma?
So there isn't, in part because things just keep changing. That is almost impossible to tell with 3 drugs being approved in the past year for patients who have myeloma after multiple relapses, and so that is an extremely difficult moving target. I tell people how about 10 years ago I told a patient that at that time, about 10 years ago, 15 years ago, the standard life expectancy was 4 years. And so I told her, well, she asked me, how long do I have to live? And I said, right now it's 4 years. So at 4 years, she sold everything, sold her house, and she lived another 3 years beyond that because the technology kept changing. New therapies kept coming out, and that's happening at a more vicious pace than it did 5-10 years ago. So that's a really impossible thing to tell with, and for good reason, that there's so many new things and so many therapies coming out.
Well, that's a great reason for that to be unanswerable at the moment. Jackie actually asked a really good question that I hear in many different cancers. So she said that she noticed that in your categories of therapies, you put clinical trial under every category. And she says that she thought clinical trials were only used for patients who couldn't tolerate the already proven medications.
Oh, I just love that question. So it used to be that way. So it used to be when we had very limited therapies for myeloma, that it was only for patients that had relapse refractory or the very worst myeloma. Now, as we have so many therapies and the science is looking at, MGUS, smoldering myeloma, newly diagnosed myeloma, relapsed myeloma, there is now studies for every stage and every situation. There's studies for smoldering, there's lots of studies for smoldering, for maintenance therapies, for induction therapies, for relapse therapies, for more than 3 relapses, for less than 3 relapses. And so there is now, for every stage, for every place, there are clinical trials available for us to push that needle forward and hopefully pushing that needle towards a cure.
Great. And I have a question here from Riche in the chat. That's a question about spine pain. And pain is a topic that comes up a lot in myeloma. Her specific question is, have there been studies on spine pain after stem cell transplant and remission? If you're in remission, why would you still be having pain?
That's because they're all good questions. The one thing that I didn't mention, when you're treating newly diagnosed or relapsed myeloma, are a lot of the supportive care, supportive therapies that we give, and specifically the bone strengtheners, Zometa, or Pamidronate, or Xgeva are the bone strengtheners that we use to strengthen the bones, because myeloma will go to the bone. It can cause those holes in the bones, and especially the spine is especially sensitive to that. And then there can be fractures of the spine, which can cause spine pain. And those therapies, the Zometa, the Xgeva, and the Pamidronate, can help build back that bone that was destroyed after you get control over the disease. And so what I tell my patients is that when they first come with myeloma, they'll have pain. And that pain in their spine will be because the myeloma has invaded, that area of the vertebral body and is occupying a space which is painful. The therapies that we have now are so good that all of a sudden, after a few cycles of therapy, that myeloma that was holding up the spine is gone. And now there's nothing to hold it up, and it collapses a bit, which can cause pain. So we used to always see pain. We still see pain with newly diagnosed patients. Now we see patients that have some pain when they come in, and their pain gets worse when they start, because these new therapies kick in so quickly that the bone strengtheners haven't had time to build up the bone before the disease is gone or begins to respond. And so it is, and that pain can occur with after transplant and can continue on, but it should get better. It should become better over time as the myeloma gets under more control and the bone strengtheners help. And one other thing that recent studies have really been showing is that vitamin D helps with the bone health and helps with the bone recovery with myeloma. So it does occur, and it does get better. I just saw a patient right before I came here who had intractable pain after we started therapy. And now, thank goodness, we've almost weaned her off her pain medications because she's done so well, but we continue to give her that bone strengthener to make sure those bones become, as strong as possible.
This is another question about COVID-19 and how strict should people be with having people come visit. Here's somebody talking about a relative who lives in Kenya and just had COVID-19 who wants to come visit and stay. Should somebody who is in treatment for active myeloma have people visiting them in their home?
That's a really good question. But that, because especially with someone who's on treatment who is, in particularly, a vulnerable population, that really trying to adhere to those guidelines for social distancing is really preferable. And someone who had COVID, who maybe not that person, but someone else who may be an asymptomatic carrier, if they visit, could be very, very problematic in having the disease. So it breaks my heart. I can't see my mom because she's in an assisted living. Because of COVID here in Michigan, but I just keep thinking that eventually all this will be over, and we can go to a Red Lobster that after this is all over. But right now, we really do have to hunker down and follow those guidelines and be very cognizant of them.
I'm going to jump to a question from Sean, who's a 64-year-old female diagnosed 3 years ago. She has 3 adult children, 40-ish years old. Is there anything that her adult children should be looking for in their physical health to be proactive about?
So, one thing that we're trying to get we'll talk about, I think, in the next couple of days, clinical trials on is looking at family members of patients that have myeloma. So, earlier I said that, their myeloma isn't directly inheritable. It's not like colon cancer or prostate cancer, which has or breast cancer that can have a gene and be more directly related. Myeloma is complex. There may be some points that are hereditary, but also, part of having myeloma is being exposed to different things. Is your exposure history to a variety of things in the environment. And the reason that myeloma occurs in older persons is that it takes time to be exposed to enough things to finally have those plasma cells become mutated. And so, what we recommend for family members is to seek out clinical trials, but to be kind of aware of things like fatigue, anemia, kidney changes, kind of those crab things, and also there was a study that was done years and years ago of people with MGUS that were randomized to either taking a vitamin or eating fresh fruits and vegetables. The study didn't get a lot of press because it wasn't the vitamins that helped keep MGUS from progressing, but it's actually fresh fruits and vegetables and those macronutrients help the immune system to keep things under control. And there was another study that was actually, interesting enough, done in Iceland, where there's not a lot of genetic diversity in Iceland. And they looked at the same thing about patients with MGUS and smoldering myeloma, and actually that people who in Iceland who again had fresh fruits and vegetables and fresh foods and limited processed foods actually had less progression to disease than people who were that had moved to the city or moved to the United States or eating more processed foods. And so staying active and trying to limit processed foods, drinking water, and being cognizant of some of those symptoms is what we're, and being involved in clinical trials where available is really the thing to do.
Great. And I do want to let everybody know that no question will go unanswered. We will, even if we have more questions at the end of the night than we can get to, we will keep your questions and get answers to them. And everybody who's registered for the webinar will get a copy of this, a link to being able to watch this webinar again, as well as that handout that answers questions. But I just wanted to make sure that people knew that. And then there are a lot of questions here that have to do about food and vitamins and supplements. Things like, one person was just asking for you to, was it vitamin D or vitamin B that
Vitamin
you said?
D. Yeah,
D is in dog.
vitamin D that helps to build bones. Is they have there was a study that was done by Mayo showing how much that helps. I'll be the first to admit that I was not strict with my patients with a vitamin D until I saw that the data shows how well patients do with vitamin D supplementation as being really an adjunct to using the bone strengtheners. And so I really do now. I think hopefully everyone's taking their vitamin D along with their therapy, even through maintenance. And so that was vitamin D as in dog.
Okay, and then is it necessary to stop antioxidants like vitamin C and green tea in addition to stopping leafy green vegetables the day of Ninlero?
So not so much vitamin C. There was some talk about green tea, being an issue. And again, the one kind of caveat to that is that, there wasn't going to be a trial where they were going to have patients with myeloma and give them green leafy things to see, is their therapy not going to work? I mean, that would be unethical. So we know this in a laboratory. We don't know this in people. But I think that the things that are kind of, the recommendations, if it's green that day, just don't take it. But every other day is fine.
Okay, and then
and I should mention that's just bortezomib. That's just Velcade. Carfilzomib, all the antibody therapies, Revlimid, and steroids. Unfortunately, there really is no interaction.
Okay, and then two more supplement questions. One is that there's talk about taking zinc and vitamin C to help combat illness in general and maybe COVID. Do either of those or any other over-the-counter treatments interfere with multiple myeloma drugs?
The blanket answer is no, that we know of. I would definitely, depends on the therapies and definitely if someone's on the clinical trial. So, the blanket answer is I discuss that with your doctor depending on the regimen that you're on. So it usually isn't a problem, but, to make sure your doctor knows what supplements you're taking.
And then the vitamin B12, could that help with neuropathy?
With neuropathy?
Neuropathy.
Yeah, so when patients with myeloma can get deficient in vitamin B12. And B12 is, of course, one of the B vitamins, and both folic acid and B12, when low, can cause neuropathy. Some of the myeloma therapies can also cause neuropathy. And so I do, when a patient has neuropathy, and even when patients come in with newly diagnosed myeloma, I'll check their B12 levels and supplement that, especially if it's low. But again, there are, myeloma itself can cause neuropathy, and some of the therapies can also cause neuropathy. But ruling out something reversible like vitamin B12 is a very good idea.
And then to get back to vitamin D, how much do you recommend when asking your patients to supplement?
Yeah, and that's a bit dependent on a patient's kidney function. And there are weekly and daily regimens for vitamin D. A 1,000 units is kind of your standard, vitamin D that are over the counter. But yeah, I would definitely, discuss that with your doctor about what fits best with your treatment, and especially with the kidney function.
Great. Here's a very different question from Mike. He says that in his treatment, there's been a hierarchy that had to be followed in regards to what chemomeds he could get. For example, he couldn't start DARA until other treatments had failed.
Yeah.
And why is this? Does this have to do with the, keeping drugs from going obsolete? Is it, why?
And that's a really good. I haven't had that question before. That's very good. I think the last person asking that question was one of the doctors in training. So that's a good question. So when drugs are approved by the FDA, after they're approved by the FDA, then usually the insurance companies are kind of obligated to cover them. And the drugs that are approved are, they go through clinical trials, and usually they're first approved for patients that have the worst myeloma, that have relapsed after multiple lines of therapy. And then it begins to move from patients that have failed 3 lines, the patients that failed 2 lines, the patient that failed 1 line, and ultimately to the patient that's newly diagnosed. And the FDA approves regimens along the line, and the research kind of follows that too, that we don't start a new drug in newly diagnosed myeloma patients. We have it prove its worth in the most at need, the patients that have that have relapsed myeloma, and then we work forward. The FDA, when they approve a regimen, they'll say that this is approved based on the clinical trial for only 1 prior line of therapy, or after someone has failed 2 lines, primarily because that's what the research proved its worth. And so the FDA approves it in that way, and therefore the insurance companies approve it in that way, where they will say that the FDA insert, the package insert says you have to have failed this and this before the FDA approved it, and therefore the insurance companies follow that line. But as these therapies begin to prove their worth, the FDA frequently changes their approval to earlier lines of therapy based on what the research shows.
Great. And you were saying earlier that one of the newer therapies that had been approved actually didn't show to do any better in first line when offered to newly diagnosed. And so, yeah. And that was kind of unexpected result.
That was kind of unexpected. It's kind of like, the new car thing, that, that RVD was a car that we were driving for a few years. And then, then carfilzomib came out, and that was a newer car. So, we jumped in a newer car and we said, well, this is a newer car. And really the old car are going to work the same. But that is kind of a surprise, that for standard risk patients, that it didn't improve upon it. The one thing that it did improve upon is how deep the responses were. So patients that receive, carfilzomib Revlimid dex as compared to Velcade Revlimid dex, that the responses were deeper. They went deeper on that Iceberg model, but it didn't relate into how long they stayed in their response between the two therapies. So that did come as a bit of a surprise, but that was for standard risk patients. For high risk patients, we still need to do some more work on.
Okay, and we have time for probably 2 more questions. Riche is saying that it's funny that you said multiple myeloma is a cancer that targets older adults. However, Riche says, I was 47 when diagnosed. Does research explain reasons why the cancer also can hit younger adults?
That's a really good question. So the one thing about myeloma is that everyone has a different journey of how they got to the disease. So, which is why patients with myeloma are very different from each other. There are chronic myelogenous leukemia is a very rare type of leukemia. That type of leukemia is characterized by one cytogenetic abnormality. Anyone in the world who gets that type of cancer has the same mutation, and the disease is the same in everybody. And how they, the age they could get diagnosed is basically the same. That disease is the same in everybody. Myeloma is much more heterogeneous than that. And how what exposures did they get, what pre-existing risks that they get, and what combination of events, cause that myeloma to happen is unknown. And it's not one in particular event. So, someone who works at an oil refinery may never get myeloma. Someone who was exposed to gasoline when they were growing up and then got exposed to radiation in an airplane and then got exposed. It's an accumulation of risks over the decades and decades of life. And the different combination of how that may have some people develop it earlier, and the combination may have it develop somebody when they're 90 years old. And so it's very variable from person to person, and which has made it very difficult to figure out, well, what's causing this? Because, you'd need a really good time machine to plot all the things that happen. And that's what some of the clinical trials that we're doing is trying to look at, is looking at, people who have a higher risk of developing a myeloma. Like as we had mentioned before, primary family members of patients with myeloma. And then tracking to see what happens to them, to see if we can get an idea of what events actually occur to develop myeloma. And that study hasn't been done yet, and it is a huge undertaking. But I would hope that that trial in looking at the course of this disease, and there are other studies being going on. There's one similar to this in Iceland. They're trying to figure out, how does this happen? Why does it happen at different ages? And to try and answer that question.
As our last question, and we will make sure all questions get answered, but as our last question tonight, is there any data on extended use of Revlimid and side effects from that? Because Revlimid is a drug that we hear myeloma patients taking multiple times in multiple therapies.
Yeah. And so, the upshot. So the upshot about long-term use of, I guess one upshot is that we've been doing Revlimid for long-term therapy for a long time, a long time. And so we have, a decade plus of experience in patients being on Revlimid for very long periods of time. The upshot is that from that, we know that long-term Revlimid helps keep the disease under control. It helps to keep, once you're down on that Iceberg model, it keeps it down there for long periods of time. And Like I mentioned earlier, that there's studies that when they say you can stop early, myeloma recurs early. So the good news is Revlimid and other maintenance therapies have helped to keep the disease under control. The downside is that there are some side effects from long-term Revlimid use, and in particular, that there is a risk of having a secondary cancer, so of having a cancer or a second cancer occur after having a transplant and being on Revlimid maintenance. In fact, when that was first found years ago, the FDA, told us to, stop the clinical trials, and the FDA really investigated what that meant. And the incidence of having secondary cancers ultimately ended up being very low. That it ended up being about 2 to 3% of patients that were on maintenance therapy. And when they looked, and a lot of those cancers that occur with long-term Revlimid maintenance are things like a basal cell, skin cancers that you would burn off with a dermatologist, or other sort of minor a nuisance, I guess, cancers. There are other severe cancers can come about, like bladder cancer, kidney cancer, and lung cancer. But again, those are really rare. And when the FDA looked at it, they showed that the benefit in keeping patients alive with Revlimid maintenance vastly outweighs the risk of developing a second cancer. So I tell my patients that just because we have successfully treated the myeloma doesn't get you out of having mammography, colonoscopies, and having a lot of those other healthcare, primary care and healthcare therapies and investigations done. And that's really how you prevent a lot of those secondary malignancies, is being cognizant of your healthcare. The last thing that can happen that is a bit more bothersome is diarrhea. That we now know that when patients have been on Revlimid for a while, they can develop diarrhea. And that diarrhea occurs from different causes, and is usually, if it's mild, something like Imodium can help with the diarrhea. We've recently, over the past few years, found out that sometimes the Revlimid has the gallbladder and the bowel not talking well to each other. And your gallbladder you use, when you have fatty or fatty meals. And so, and the Revlimid causes where sometimes you eat something fatty, you'll have diarrhea. And so a medication called cholestyramine can help with the diarrhea associated with Revlimid when when something like Imodium has failed. But another thing that I tell my patients with long-term Revlimid use and any other maintenance therapy is that when we start treatment with myeloma, it's like an airplane is flying like in an airplane to the next big city. You're in an airplane for an hour and a half, and it's I'm 6'5", and it's always uncomfortable, and someone's always backing their chair up, and my knees hurt, and when I get off the plane, my knees hurt, but it's only an hour. That's like induction therapy for myeloma. Maintenance therapy is like flying from New York to California. Is a much longer trip. It's more of a marathon than a sprint. And I definitely try to get as comfortable as I can in my seat, before, when that flight starts. And so, with maintenance Revlimid, we find the right dose that fits into this lifestyle. We find the right labs, and try and make it as comfortable as we can. And I do have patients take vacations. So sometimes they go on vacation and they'll say, for the next 2 weeks, so I need to take my maintenance Revlimid. I said, no, you're going on vacation, and this is a long-term project. It's not a short term. And so it really is, I definitely work with my patients to find what's a comfortable way that we can keep this maintenance therapy going, because it definitely has its benefits.
Great. Well, Dr. Cole, we really thank you for coming and contributing your time, giving us this important information, and especially for being willing to take so many questions, because
For sure.
I know
I love questions.
well, that's great, because patients and caregivers really love answers. And they don't always get answers, and especially when you're in the middle of explaining it, to answer right then is really helpful. So thank you so much for contributing your time, sharing with us. Cancer Support Community also wants to thank our generous sponsors for this program: Sanofi, Takeda Pharmaceuticals, and Bristol Myers Squibb. Their support made tonight possible. And we would also like to ask folks who are listening to this right now to take a moment and complete our webinar evaluation survey, which will pop up next if you're with us live. And if you're listening to a recording of the webinar, you can access the evaluation survey by going to surveymonkey.com/r/MMM We greatly appreciate any feedback you may have. It's really helpful for you to help us in this way. So thanks for your participation. Enjoy the rest of your evening. And this recording will be available on our website, on Cancer Support Community's Facebook page within the next week. And we'll email everyone who registered with links to those recordings, and also with any of the remaining questions that weren't able to get answered in the hour and a half that we had tonight. So have a great evening, and thank you so much.
Thank you. Thanks, everybody.